Today we're talking about a true life or death medical emergency. This is a condition where the clock is ticking and the heart is literally in a fight for its life. We are talking about cardiac tamponade. So picture this. The ambulance doors fly open. A patient is rushed into the emergency room. They're panicked, they can't catch their breath, and you look up at the monitor and their vitals are just cratering. The whole team is scrambling because this person is clearly in shock. But why? The cause isn't obvious. What's actually happening to this patient is, well, it's terrifyingly simple. Something is physically squeezing their heart from the outside, and it's stopping it from doing its job. So the mystery we have to solve together right now is, what is it, and how did it get there? Okay, so let's get right to the heart of the matter, literally. To really get what's going on, you have to think less like a doctor for a second and more like a plumber or an engineer. This is all about pressure building up in a closed space that has absolutely zero room to expand. This whole crisis has a name: cardiac tamponade. See, your heart doesn't just float around in your chest. It's wrapped in a thin but really tough little bag called the pericardium. Normally, there's just a tiny bit of fluid in there for lubrication. But in tamponade, that sac starts filling up with extra fluid. Could be blood from trauma, could be something else, and that fluid has nowhere to go. So the pressure builds, and it physically crushes the heart. And if the heart can't expand to fill with blood, well, it has nothing to pump out.
Now this is probably the single most important concept you need to grasp to understand tamponade. It's not always about how much fluid there is, it's about how fast it got there. If fluid builds up really slowly, over weeks or even months, that pericardial sac can actually stretch and make room for a huge amount, sometimes more than a liter. But if it happens fast, say from a stab wound, the sac has no time to stretch. And in that case, as little as 150 milliliters, that's less than a can of soda, can be absolutely catastrophic.
Okay, so let's get back to our patient in the emergency room. How does a doctor even begin to suspect that this is what's going on? Well, they have to become a detective, hunting for these subtle telltale clues that all point to one thing: a heart under an incredible amount of pressure.
There's this classic trio of signs that every single medical student learns. It's called Beck's Triad. First, you've got hypotension. That's just super low blood pressure because the heart can't pump. Second, you see these bulging neck veins because all the blood trying to get back to the heart is just backing up like traffic on a highway. And third, when you listen with a stethoscope, the heart sounds are really faint and muffled because you're trying to listen through a layer of fluid. But here's the kicker. If you actually see all three of these signs, you are very, very late to the party. The situation is already critical.
And that is exactly why doctors look for a much more subtle but really important early clue. It's got this fancy name, pulsus paradoxus. Now, don't let the name fool you. It's not a paradox at all. It's just a big exaggeration of something that normally happens. Basically, a doctor checks the blood pressure and looks for a drop of more than 10 points when the patient takes a breath in. It sounds weird, but it's a brilliant clue to the bizarre physics happening inside that chest. So why does this happen? Let's walk through it. Imagine the two main pumping chambers of the heart, the right and left ventricles, are like two balloons squished inside a rigid, fluid-filled box. When you breathe in, you naturally pull more blood back to the right side of your heart, so that right-sided balloon, the RV, gets a little bigger. But since it's in a fixed box, the only way it can expand is by pushing the wall it shares with the left ventricle over to the left. This literally squishes the left-sided balloon, the LV, making it smaller. A smaller LV can't fill up with as much blood, which means it can't pump as much out, and for that one beat, your blood pressure drops. Now, physical clues are great. They get you on the right track. But to be 100% sure to really seal the deal, doctors need to actually see the squeeze happening. And for that, they bring in the technology. The absolute gold standard for diagnosing this is an echocardiogram, an ultrasound of the heart. The first thing you'll see is pretty obvious: this big black area of fluid around the heart, the effusion. But the real smoking gun, the thing that makes you say, aha, that's tamponade, is seeing the right side of the heart, which operates at a lower pressure, physically gets squished and collapse inward at the exact moment it's supposed to be filling with blood. That diastolic collapse is the definitive sign. Of course, in an emergency, you can't get tunnel vision. A patient this sick could have other deadly problems, so the team has to quickly rule out the other big imposters. Could it be a collapsed lung, what we call a tension pneumothorax? Well, then you wouldn't hear any breath sounds on one side. What about a massive blood clot in the lungs, a pulmonary embolism? In that case, the patient's oxygen levels would probably be in the basement. By checking for these other key signs, the diagnosis of tamponade becomes crystal clear. So, the diagnosis is made. It's tamponade. There is absolutely no time to waste. The story now shifts completely from diagnosis to pure action. It's a race to get that pressure off the heart before it stops beating entirely. So the team jumps into action. They give the patient oxygen, they get big IVs started, and sometimes they'll give a big rush of IV fluids. Now, this is just a temporary fix, a bridge. The idea is to raise the pressure inside the heart, just enough to help it push back against the pressure on the outside, buying a few absolutely precious minutes while they get ready for the real solution. And this is it. This is the fix. It's a procedure called pericardiocentesis. Using an ultrasound to see exactly where they're going, a doctor carefully guides a needle through the chest wall right into that fluid-filled sac. And the second that fluid starts to drain out, the effect is just immediate and unbelievably dramatic. The pressure vanishes, the heart can finally fill up again, and with the very next heartbeat, you see the blood pressure start to climb back to normal. It is one of the most directly life-saving procedures in all of medicine. So, as we wrap this up, we come full circle, right back to that single most important lesson from this whole story. It's the powerful principle that really governs this entire emergency. In cardiac tamponade, it's not how much, it's how fast. Remembering that it's the rate of accumulation, not the total volume, that's the key to spotting the danger, making the diagnosis, and ultimately saving a life.